I think we perhaps first know that the in stroke, 10% of the world population dies from the strokes. That's the importance of it. The blood pressure which causes the stroke, I think we really like to know that it is a modifiable risk. Treatable and manageable situation comes up. Now, a stroke is a medical emergency. We have few things on tips that when we see in a general practice, you being the specialist, of course, it eventually comes back to you. But I think we have to be careful as to see that the person who has reported to us some problem, we should act fast. And with that, we have these various little known symbols that which is called FAST, F-A-S-T, face, arm, and speech and time. So we look into these and see if there are any problems. And if we get to know that there are any problems, then it's a medical emergency, and it has to be seen to it very quickly. Blood pressure, of course, is highly important. And we also know that there is another symbolism attached to it of ABC, which is age and blood pressure and clinical features and the duration of the symptoms. And they each carry 1 point, except that the duration of symptoms carries more points. For example, if you're 10 to 59 years of age, it carries 1 point, and if you're over 60, it carries 2 points. This is to describe, when we say ABCD, we're describing the severity of the stroke. And therefore, when we know the severity of the stroke, we should also know how urgent it is to get going on it. So there was a good discussion in the past as to what we do as a GP. Shall we or shall we not? When we see a patient like this, shall we give him an aspirin or shall we not give him aspirin? A long debate has gone on for umpteen years. And from whatever I gather from my senior colleagues and learned colleagues, that it is better if we give aspirin to start off and then leave it to the specialists to make investigations and then further management. Then, of course, from the general practice point of view, we send this patient to the specialty, and then the patients come back, and then the patient is to be cared for probably many, many years by the general practice. And in that, we have to make sure that we do certain elements, certain things to reduce a second stroke, number one, and to make sure that the first stroke that it was there should be reduced to a minimum or leave it completely off the hook for the rest of his life or her life. So what do we do in general practice? We advise them to stop smoking if they do, to reduce weight, very important if they were overweight, and then low-fat diet. We reduce the dietary salt if the blood pressure is high. And we also give statins for certain group of people, but not to all. But if it is a thrombotic episode, then statin is desirable. Then, of course, we have to come back to the blood pressure. Blood pressure, of course, is very important, but I think some people might like to know what does cause the blood pressure. Well, as we remember in our student days, it used to be the cardiac output and peripheral resistance and the ratio and whatever. But in simple terms, I think if we remember that it's the peripheral resistance, it's very important. And then there are sympathetic stimulizers in the nervous system, renin, angiotensin system, and vasodilator deficiency from the kidney, such as bradykinin. That's just a very brief few lines I have given the reasons for high blood pressure. Then, of course, there is a malignant hypertension in which we get vasculitis, which, of course, affects every place in the human body. All organs get affected, and it's a horrible thing to have, and it's a condition in which I think general practice is not the suitable place. It's the specialized hospital unit who can do that. So to improve the blood pressure, we have many drugs in which we treat them. But I think what I find in my general practice is if I really know that this patient is a hypertensive, he's been hypertensive, we don't know for how long because he's been checked by our practice nurse or by someone other in our practice, and then I feel that I want to have a chat with the patient rather than straight put him on various drug treatment like calcium channel blockers. We all know that. But I think the first thing I'd like to do is I would sit him down in front of me for about a few minutes, 10 minutes, and explain to him he has got blood pressure, which, if continued, and then depending on the age as well, if continued, it will give him what is well known as stroke. And if he gets a stroke, the quality of life would be highly endangered. And if we get him better from one stroke, we make sure he doesn't get a second stroke, because if he gets a second stroke, it's worse than the first one. So to have him sit down and have a very friendly chat, I will not try to frighten him, but I will take him on board that he and I, or she and I, are a team to tackle the problems and the pains of high blood pressure, which he is suffering from. Because eventually, if untreated, give him a stroke, a heart attack, kidney failure, and many other problems. So that's where I begin, and then gradually introduce items depending on his blood pressure. We will give him items like bendrofluozide to start off. If that doesn't work, and we give him ACE inhibitors, we add calcium channel blockers, and so on to other tablets, other drugs, and hopefully we bring his blood pressure down. I think it is also important that giving him only the medication is not enough. We must tell him that so much the medical profession can do for you, but so much you must do for yourself. For example, if he's overweight, he should reduce his weight. He should do exercise. He should have healthy habits. Eating habits. If he's on the overweight side, we want to reduce his weight. and so on, so that he knows that it's a teamwork. The drugs are not only they are not only the panacea of the treatment. It's a joint effort by the patient and the physician that must go on for the eventual success. It's absolutely minefield of all the diseases. The diabetes perhaps is on the top of all problems and pains of the medical science. We have been told that there are problems apart from, because I'm on stroke and on this, so I will restrict myself to the stroke rather than go into the complications, for which if we talk would be here for hours. Glycemic control is very important, as you know, but much more than that. I think it's a reduction of the peripheral problems have to be looked into, which means we must bring his blood pressure down to offset the cardiovascular risk. So let me say again that in diabetes, although it's human nature that, oh, he has got a high glycemic situation, so all our efforts go into the hyperglycemia that reduces HbA1c down. But much more than that, I think the blood pressure has to be brought under control. Very, very important. Because that goes into two components. If the blood pressure is not controlled, we will have macrovascular complications and microvascular complications. Both are extremely lethal. In macrovascular complications, if the glycemic control and the blood pressure is untreated or partly treated or unsatisfactorily treated, we can get a heart attack. We can get microvascular complications which end up in nephropathy, the retinopathy, cardiac conditions, and myopathy. Micro and macrovascular complications may go together. So CVD, we have to confront the CVD risk reduction. Very, very important in diabetes. With blood pressure control, statins if necessary, and antiplatelets. Other than that, if we want that the diabetes should not make him go into a risk factor of a kind in which he gets a stroke, then the diabetes will have to be looked in as a whole. There's a combination, so much combination of and overlapping of the problems of hyperglycemia. We also have to make sure that it doesn't get hypoglycemia. Hypoglycemia is much worse than hyperglycemia. But I think enough for me to say that the diabetes also causes micro and macrovascular complications which can lead to stroke. Thank you.